So thank you, Bennett, for this introduction and for invitation to speak to you guys. It looks to me like what I'm seeing here is a very young audience, both chronologically as well as in tenure. So most of you, it seems, are students or postdocs, correct? Yeah, very many nodding heads. Excellent. So let me tell you, so I'm an MD PhD, and what that means is that I basically am now uniquely suited to disappoint everybody because I split my time about equally between my clinical activities as a pathologist, and I just do medical practice as a pathologist, which I'll describe to you in brief. And also scientifically, I direct this core laboratory. I have my tiny little lab with my science. So if anyone is still an undergraduate, I'll be delighted to let you know what fantastic opportunities exist for people to spend 3.5 years of medical school and 5 years of PhD to then go through residency, be very old and tired, and then be able to disappoint audiences like this. So next slide. Ooh, something happened here. I'm so sorry. Why there is no next slide? This is an overview. I'll briefly define what pathology is, and then I'll focus very specifically on kind of a warped view of the patient through the eye of the pathologist, meaning that we'll view patients through our procurement techniques and the specimens that come out of these patients. I'll do that perhaps not as with so many fantastic details and phenomenal technologies as Dr. White, but I'll give you just a picture of my day at work and what my considerations are in terms of what we do. And I practice cytopathology. I'll define it later. And then I'll tell you a little bit, maybe relating back to what Dr. Licht was saying about analyses of molecules, because they do impact not only what I do, but also how I practice in my day-to-day level. Hello? So the title of the talk was histologic analysis of tumors, but really what that means is a pathologist's role in helping to define the therapy. This is why I exist. I obviously exist to diagnose these lesions that Dr. White biopsies and gives me, or a surgeon cuts out of somebody and gives me, but fundamentally I do to assist Dr. Licht in what kind of drugs, what kind of therapeutics is he going to use, which is now being based on molecular technologies that we're going to go through. What am I doing wrong? It's not changing slides. Okay. So the definition of pathology is literally, it's from the Greek. Pathology is a fairly old discipline of medicine, and it's pathos and logia, meaning study of suffering. That's the literal translation. I don't want you to think that pathologists study suffering or suffer every day, but this is essentially a study of disease. What we do is we take specimens and then we try to figure out what is the mechanism of that disease process. We describe it first, and then we try to figure out what is the essence, what is the basis of the problem, why certain things are happening a certain way. The practice in the United States of pathology, this is essentially, we are post-medical school, we go to a residency program like any other specialty, like radiologist or medical oncologist or whoever else. But our practice is divided into clinical pathology and anatomic pathology, and I just want to define these terms because they are very meaningful to us. Most of us undergo residency in the combined APCP training. Some of us, maybe 20–30%, do either anatomic pathology or clinical pathology. So what is clinical pathology? It arose from basically taking liquids from people: blood, urine, cerebrospinal fluid, etc. So once these are taken, when these types of specimens or categories of specimens are taken, then pathologists figure out what to do with those. For example, you have microbiology lab within clinical pathology. So if the patient is suspected of having an infection, then we take it and we culture bacteria, we culture fungi, we speciate them using a variety of molecular technologies, right? We can also figure out what virus is growing. The other branch of this is blood bank or coagulation. So all blood transfusions, blood types, blood groups, all the particular transfusion reactions that patients may undergo, or they may require blood products to restore their coagulation. Dr. White was talking about a patient who had had a little bit too many beers for 40 years. And those patients with synthetic liver functions are compromised and they develop coagulopathy. This is why she didn't want to biopsy him, okay? So we, in pathology, have products. We have fresh frozen plasma, we have concentrates that can restore particular coagulation abnormalities. You've heard of hemophiliacs, okay? We have factor 7, etc., 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 to restore these people back. So the blood bankers and coagulation specialists manage that. Those are clinical pathologists. The other branch of this is chemistry. That's not chemistry that perhaps you studied in college or even in graduate school. What that means to us is that we take particular protein and ion analytes that exist. You have to have a certain level of sodium, potassium, etc., other ions in your blood in order not to get an arrhythmia, in order to function. Kidney is responsible for it, and then medical doctors will make judgments. Medicine specialists, meaning internal medicine subspecialty trained physicians, will make decisions on the basis of these laboratory results. So this is essentially what is called the laboratory in the hospital. They will produce particular laboratory results that relate to the state of the patient, and this is all under pathology. Then there is a group of people who practice anatomic pathology. I'm one of them, and this is divided into two major things. One gigantic, one rather minor. The minor is autopsy and forensic pathology. Autopsy in the hospital is really determination of cause of death. This is now very, very infrequent on a population level that we take autopsies. The other aspect of this is forensic, meaning determining a cause of death because there might be some wrongdoing. Murder, suicide, so homicide, suicide. Determination of these are under states. Hospitals usually don't deal with these cases because these are non-medical reasons for people to die. So those anatomic pathologists subspecialized in those areas. And then the gigantic branch of pathology, the one that really is the basis of what we do in cancer today, okay, is surgical pathology. It has, these are the people who essentially diagnose everything that comes out of all the tissues that come out of the patients, all the biopsies, all the surgical specimens, major excisions, minor excisions. And then within that, there's also a subspecialty called cytopathology. And these are people who look at cells or tiny little specimens, sometimes biopsy processing. You will see that how I'll show you on the case. That obviously is the most important discipline of medicine. And clearly the one that's most difficult. You need fantastic skills to be able to diagnose cancer on few cells rather than on a big chunk of a surgical excision. That obviously is very trivial. You can see that I'm making a joke because that's what I practice. So my subspecialties, I know there is a board, again, you have to be boarded in anatomic pathology, you may be boarded in clinical pathology, but then in order to be boarded in particular subspecialties of anatomic pathology, such as cytopathology, that's another fellowship, another training, another set of regulatory aspects. I'm telling you this because this is sort of, you will see items here that I will comment that do not necessarily relate to science or to the practical aspects of diagnostics of cancer, but they also relate to regulatory environment that has very profound impact on our training and also on the interaction between the MDs and the PhDs and how basic scientists can gain access to medical problems and knowledge thereof, okay? Because that is really the essence of translation. This is why we do what we do, at least what I try to do. So I think that now the distinctions between clinical pathology and anatomic pathology are clear to you. And aside from tumor markers like alpha-fetoprotein or carcinoembryonic antigen, which the clinical pathologists do, we will no longer talk about them, but rather focus on the tissues that come out of the patient and discuss what anatomic pathology does. So here's the first step of anatomic pathology. You see the drawings, okay? They are taken from Johns Hopkins Manual of Grossing. So what is grossing? Meaning we tend to examine things under the microscope, so that's a microscopic examination versus a gross examination of the specimen for grossly visible abnormalities. Dr. White was showing you a cross-section of the liver with a tumor inside it. That is the definition of gross examination. Here's a little bit more of an elaborate diagram of what we do with a Whipple resection or pancreatic duodenectomy, meaning patients suspected or Dr. White had diagnosed a mass in the pancreas, and she finds it very suspicious for a malignant development. She wants to know whether that's adenocarcinoma. Then we do a biopsy, and yes, it is adenocarcinoma. Then that patient, if there are no metastases, will undergo a surgical procedure to excise that tumor in toto. Since the piping down there is quite complicated, both on the vascular side as well as on the gut side, this is the specimen that comes out, and that comes to first contact with pathology. So a pathologist will look at this specimen and they will cut it. You see the scissors and the gloves and all of that in this diagram. This is what we do at the grossing station. Why do we do all this? Well, we need to assess where the contact points of the cancer with the rest, meaning the patient, are, in order not to leave something behind. And you had demonstrations how this works on radiology, correct? Because if you leave it behind, then it'll regrow and eventually cause morbidities or death in the patient. So we examined the specimen, we cut it open in a very systematic way, and this is just an illustration. But the purpose of this is that arrow pointing to the guy with forceps having a little piece of reddened something. That is that cross-section of a particular area of this specimen is then being measured and described and placed appropriately into cassettes. That second piece is this looks like a really sort of breast surgical biopsy because it has that darkened black artifact on it. That probably is a cautery artifact, one possibility, or the other is ink. We put ink on the margins. If you cut something out and then you put ink on it, then you know that only the inked area is the one that is directly contacting the patient on the other side, the patient presumably out of the OR at that point. And then if the lesional cells or the structure that's abnormal affects that, then we call it margin positive. That means that the surgeon probably either should have sent us a frozen section to see it in real time, or the patients should undergo a re-resection of that particular lesion. That happens. Sometimes it's very difficult to do this in real time because there are multiple contact points, okay? Then on the bottom of this, there is a tub. There is a plastic Tupperware tub filled with fixative. Pathologists drink, breathe, and eat formalin. 10% non-alcoholic phosphate buffer formalin. That's our lifeblood. I bleed formalin. This is a fixative. There are very many fixatives. You can fix things in ethanol, which I also like, not only like that guy with the beer, but also because it's a precipitating fixative, unlike formalin, which is a cross-linking fixative, which does not cleave DNA, and then Dr. Licht is very happy because he can recover long stretches of DNA as opposed to short 300 base pair fragments. But also it affects how tissue then looks under the microscope. So you now see a row of cassettes in formalin they need to fix, and this is extremely important. For example, ASCO-CAP clinical guidelines have input from pathologists in terms of how long a certain thing, a biopsy, an excisional specimen, etc., has to sit in formalin, because that affects subsequent marker studies that are then used to give people tamoxifen, give people Herceptin, etc., etc. So these processing steps that we in pathology do have a profound impact on not only molecular analyses, but also very routine, very 80s analysis such as immunohistochemistry, and I'll show you that in my case. So what happens next? It goes into this box, that machine there in the corner, okay, with the first arrow coming out of it. And the purpose of this is to take water out and put wax in, okay? The reason for this is that you need to get cassettes looking like these things green in the middle. Do you see the wax in there and how the tissue is layered? Now, water is out. This is now in wax, and now what we can do is we can put it on the microtome, and that's what this person is doing there in purple latex-free gloves. They are taking that piece of tissue, which is now well-oriented, ink, blah, 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 all these things that contains the abnormality or not, and they're going to section it at 5 micron thickness to get a thin ribbon of tissue and then place it on a glass slide and then put it in that machine on the bottom, which is the stainer. We have numerous dyes and stains in pathology. What you've heard, you must have, is hematoxylin and eosin, which is the H&E stain. That again is something that I probably look like an H&E stain, you know, red and blue, and the other colors are utterly unimportant. So this allows us to see the cells, to see the structure of the tissue, to know where the collagen is, where the cell borders are, where the nuclei or the subcellular organization, as well as the architectural aspects of the tissue, are based on an H&E stain. I think it's 99 bazillion decimal points beyond what we do. And that's the slide that you see, okay? So that little picture on the bottom is a glass slide with a piece of tissue on it with an H&E stain. It looks red, and I'll show you some of those microscopic sections. So these sections of the specimen, now you can have a case with 20 slides, you can have a case on occasion with 86 slides, or 1 slide if it's a small piece of tissue. But this is what we look at to make the diagnosis. That's the first step. And that guy back there, that's Mike Viglione. He actually is now in an affiliated hospital in Chicago. The one that's turned, his back is turned to you, I don't know who that is. That's probably some unimportant resident. But Mike Viglione is a pathologist, and what we do is we sign out cases. This is our lingo, this is our jargon. Our job is based on signing out cases. That's just for you. When you hear it, you will know what that is. Somebody sitting at a microscope, looking at the tissue section or cells, making a diagnosis. That's our process of sign out. So, what happens? Well, we basically sign something out. We have to call it a name. We have to make a diagnosis. We have to diagnose that lesion. And this is just a tiny little sample of a WHO classification of lung epithelial neoplasms, okay? So you go from pre-invasive lesions to big global terms of adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and there are hundreds. This stuff by now is about, I'm not kidding you, 120 years old or more, okay, in terms of the terms that we use. And if you go into these smaller text, I think that you can see these, right? It has the mucinous, non-mucinous, mixed, papillary, fetal adenocarcinoma, signet, and clear cell. These are very old terms that pathologists who are looking at this, and sort of like the CT developers in the 80s, this was Miecznikov in 1800s, saying like, what does it look like? Well, some of it looks like a signet, some of it looks papillary, it has papillae. So we've coined all these terms, and now, over the 100 years, we still use them because they're very descriptive, they're very robust, and they allow us to then subclassify these lesions and look at the outcome of the patient, okay? And they are consistent throughout time. They reflect a certain basic biologic truth about carcinoma. In this case, carcinoma is a malignant, epithelial malignancy, but cancer, a malignancy. They are consistent. This is how we classify them. This is how we know what we know. It's not just that we apply a name to this thing. It actually has a very deep meaning. Okay? Is that clear? And this is sort of boring and 120 years old, and you might think that this is utterly irrelevant and Peter is just some old guy talking some stuff. So, not so fast. Because why do these things look like they do? Why do they make papillae? Why do they make mucin? Why some of them are signety and some other ones are whatever? Sometimes these, I feel extremely old because sometimes ground glass, I mean, these analogies become irrelevant. Nobody knows what ground glass looks like anymore. We have plasticware, not glassware in the lab. So, but anyway, very seriously, look at the title of the first paper in pathology literature, okay? Distinctive evaluation or non-mucinous and mucinous subtypes of bronchoalveolar carcinomas, yada, 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 in EGFR and KRAS gene mutation analyses. So all of a sudden, it is black and white that the non-mucinous types have the EGFR activating mutations, all right, and the mucinous types do not. So you saw that little insane granularity on that tiny sample, the multiple terms that we apply morphologically and have been. This is old stuff, right? But they are deeply meaningful in the essence not only of the ontogeny and the biology of that disease, they have phenomenal and profound impact on novel 21st century targeted therapeutics in personalized medicine. Look at the New England Journal. Notice, of course, that the pathology guys published in some lesser impact journal, but this is absolutely correct because the high impact journal, okay, is related to the fact that somebody, Maureen Zakowski and other guys at Memorial or somewhere else, they basically took the drug and connected the dots. They found the histologic type of lung adenocarcinoma that has the EGFR activating mutations. They added an EGFR drug called erlotinib or Tarceva, and you had another figure which is very famous, which I think was on the cover, where you had the bronchoalveolar carcinoma, and Dr. White, I know, knows this photograph, where the entire lung was white, meaning it was cellular, there was almost no air in it. And then there was a picture 2 weeks later when that lung was black, because cancer melted away. Done. Magic bullet, fantastic drug. And this was based very strongly on that classification. So there is a very deep link to how things look versus what they do molecularly and how pathologists can then guide and affect that therapeutic choice. Does that make sense to everybody? Good. So now we'll go to viewing of the patient through the procurement technique. So this is my view of things. We have essentially two categories of things coming out of the patient when we talk about cancer. One is an excision, meaning that a surgeon sees the patient, does a fairly extensive, on occasion, operation, and the specimen that comes out of the patient is large. It could be a mastectomy, an entire breast, pancreatic duodenectomy, you saw. Parts of pancreas, duodenum, vessels, everything else, large gross specimen. Or we can have a biopsy, which is a small sample, sometimes maybe 2 millimeters in diameter and about a centimeter or half a centimeter long, a much smaller bit of tissue. That has very profound consequences too, because you have a large amount of tissue, meaning it's probably not limited if you want to do many assays with it. You have higher morbidity, obviously, and a higher cost. Your diagnosis is more robust because you see the entire representation of the disease, so the heterogeneity is lesser, and you can also make other comments about it. Is it invasive? If so, how deep? In a colon resection specimen, the whole staging and prognosis of a patient depends on this. And you have what I call unlimited assays, because in the era of molecular technologies, really, if you have an excision, you pretty much can do whatever you want. And that's not the limiting factor. On a biopsy, you have a much smaller amount of tissue. Obviously, it's lower morbidity. So this is the driver behind it. You don't want to hurt people and cause an excision if you can get by with a much smaller amount of tissue and lesser morbidity, and patients, even after therapeutics, going home the day off. It's not uncommon that in our clinic post-interventional radiology, people say, 30 minutes for the procedure, 2 hours for observation. You can go home and go to Saks, if you are at our hospital downtown. Cost is also an issue. Unfortunately, this is a reality that these are the adult topics in this conversation, but cost enforces how medicine is being practiced. And then you have to make a choice. You can either make a robust diagnosis or have unlimited assays, and this is also what Dr. Licht was talking about, the biggest bang for the buck. And this is the sort of the RNA sequencing idea, or exome sequencing, where actually out of everything you can get translocations, etc. So what do I do when I have a specimen? I have to make a diagnosis first, and everything else, including sometimes satisfying Dr. Licht's exotic needs for assay, is second, okay? Because there is a classification that must be produced and the clinicians have to act. There are guidelines, there are standard of care criteria, and this is my job. So no matter what, when I get this specimen, however small, however limiting, my job is to get to the definitive diagnosis of that lesion. So what are the considerations in terms of the morbidity effects in the biopsy, in terms of how I approach this? Let's take a breast, for example, and the biopsies of the breast. Breast is an external organ. Even if the patient is coagulopathic, you can probably compress that organ and watch it. And even if it bleeds, it's not going to necessarily kill the patient unless that patient exsanguinates. This is sort of brutally put, okay, but you get the picture. I mean, certain organs and certain procedures have higher morbidities, some not. Let's take lung, for example. You want to do multiple cores of that lung, you're going to give the patient pneumothorax. And then the patient needs to be admitted and have other morbidities. Let's go to the GI tract. So in a GI tract, say that you're doing a big colon, which is internal, and you're just snipping a piece of it, well, that probably is not a big deal. Say that you have a pancreas mass and you need to stick a needle or get a core biopsy. Pancreas makes enzymes to digest your food, correct? You are now going to create leaks into the tissue. You're going to give that patient acute pancreatitis from which that patient can die. So all of a sudden, how much tissue you get, what is the modality of access, and what my needs, because of course as a pathologist I want the most I can get in order to make a robust diagnosis. But I have to be mindful and I have to interact with People like Dr. White who are going to say, Kulesza, you want 12 gauge core and you want 4? That is impossible. We're going to give this patient substantial morbidity at the risk of dying. So obviously this has to be moderated, and there are guidelines to do this. There are other organs that I could talk about, but this probably is a little bit outside of the scope of this talk. It's a little bit too granular, a little bit too clinical. You just need to understand that there are certain considerations where you, for example, want to study a certain disease, that your expectation of the material available has to be tailored to what is the clinical standard of care or clinical practice. And that's where you have people like me at the Pathology Core Facility to sort of, Peter, what do you think we can get by with this? What are the kind of specimens that we can get? And then I can advise you, we need to go to large excisions. No, this never gets done. You'll never get this, etc., etc. So that's sort of the practical level of knowledge for you. So then the other sort of consideration to this, when I am on site and when I am making a diagnosis, I have to think, will there be another specimen and was it going to be good for? So clearly, if this is a surgical versus non-surgical disease, then yes, there will be an excision specimen. Say that it's a lung adenocarcinoma and it's low stage, I will have an excision because that is the accepted treatment of that disease. You cut it out and then it doesn't recur. In certain other diseases, such as lymphoma, such as small cell carcinoma of the lung, surgery is really not an option because it doesn't improve outcome. So there will not be another specimen, and I have to know this in order to assure that when I am procuring that specimen or when I'm talking to Dr. White, we get what we need at that time. The other thing that is sort of concern here is neoadjuvant effects, because if you have an invasive breast carcinoma in a particular setting, there will be a chemotherapy prior to the excision. And in about 30% of cases, you will have a complete pathologic response. What does that mean? On excision, there is no cancer left. And you've seen these examples, right? Where basically either local delivery or systemic delivery of chemotherapy obliterates the cancer to the point that there is no disease in the patient, and there will not be a subsequent specimen to either make a diagnosis or study. So what are the modalities of procurement? You had a fantastic demonstration from radiology in terms of what to do it, but let's take it simple. Okay. So clinicians via direct visualization. Patient has a mass, melanoma. Patient has a lesion on the skin. What do? We look at it, we take a punch biopsy, and we stick it in. We anesthetize first. I do these minor procedures called fine needle aspirates in the clinic where people have palpable masses when I do the same process, meaning that I can immobilize the lesion with my fingers, anesthetize, stick a needle in it, and extract some of that lesional material for me to analyze. So that's the simplest. The vast majority of the specimens that I see are coming from courtesy of people like Dr. White, and they use different modalities. The major modalities that I interact with is CT-guided biopsy and ultrasound-guided biopsy. This is where the majority of these lesions are observed, and then Dr. White says, I want a biopsy, and then we do it. The other aspects of this procurement are bronchoscopy, endoscopy. So basically you have, you have holes such as your mouth through which you can get through the trachea down to the bronchial tree to the lung, or you have an esophagus through which you can also stick a tube down in there, or you can stick a tube from the opposite end of the esophagus and further, and you can get at lesions from the lumen of that structure into the tissues. So for example, pancreatic cancer diagnostics are most often done by endoscopists, so that's an oral tube swallowed, and then from that they have an ultrasound and they also have optics, so they can see where they are and they can stick a needle out and procure a piece of tissue that is adjacent, coming out of the lumen, puncturing that, and then getting that tissue out. So all of those considerations are very important for pathologists in terms of how somebody got there. The reason is I have to know this because there are different contaminants in different places that may affect my diagnosis, and they also will present non-lesional elements into the specimen. You'll see it on the case that I'm going to show you. So how does pathology get involved in saying what is an adequate specimen to study, to make a diagnosis and to study further? The first, of course, is indirect because you have sampling guidelines. I mean, you know, say that the clinical pathologist decided that somebody's PSA is extremely high, and then urologist said, well, let's get a biopsy. There is now per protocol sextant biopsies. The prostate gland gets sampled. I have nothing to do with it. I am not on site. I don't know what's happened, but based on our observations of how many cores or what types of specimens are necessary to make a diagnosis, now we've developed guidelines that the procuring physicians, be it surgeons, radiologists, or whoever, know, oh yeah, we need to do 6 cores from this gland, we need to go here, 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 and then we will submit this to pathology. The other involvement is direct, and that's where cytopathology comes in, because that is an on-site adequacy evaluation. And radiologists, interventional radiologists, and cytopathologists interact. And this is basically when I, in real time, talk to Dr. White and say, ooh, this is not from the lesion, or this is all necrotic. Or what I do is I do an on-site adequacy evaluation of that specimen. And then we both determine how many cores and what type of specimen we can get. So the questions that I ask on site is like, what is it, right? I have to make a judgment whether it's cancer, whether it's an infection, whether it's a benign tissue. And then if I have a preliminary thought in my head, which is a differential diagnosis, what that lesion might be, then I have to figure out, is it enough for the subsequent test so that I can get to the definitive diagnosis. So here are the mechanics of this, and fine needle aspiration versus core. These are just particular modalities of procurement that are appropriate for particular sites. The techniques that we use is we smear this material on a glass slide, or we do a touch prep of that fresh tissue onto a glass slide, which then what I do is I can air dry, which provides some element of fixation and adhesion to the glass slide, and then I use an old Rokitansky modification stain called Diff-Quick, okay? And within about 5 minutes, I can look at it under the microscope and I can make a decision about what to do next. I can do a broth culture if I think it's an infection, you know, send it to the clinical pathologist to culture the fungus and see what's affecting the patient. I can do a particular media for flow cytometry if I think it's a hematologic malignancy, and then I need to talk to Dr. Licht about that diagnosis. Or I can put it in formalin, which is everything, because then I can do my IHC, I can do my H&E, and I can do molecular testing, to which we will get to. So those are kind of the decisions that will occur on site. On occasion, fellows do it, but when we are involved, we triage that specimen appropriately. So here's my case presentation, okay? It's just only one because I'll go slow and I'll show you the little pitfalls and little pathology-specific things that I do. So here's a 56-year-old lady. She has a history of polyps with high-grade dysplasia, which already perked my ears because that means that she might have a colon cancer. But now she presents with a 3-centimeter right lower lobe nodule in the lung. So already something very suspicious that needs explanation, and her clinician wanted to involve us in that diagnosis, and we're doing a CT-guided biopsy of that lesion. So this is the Diff-Quick stain of an on-site core biopsy touch prep. Basically what you do is this is maybe 1 million times magnified core, okay? So this is a core. This is a core of tissue that's in an instrument. What you do is you touch it to the glass slide. Sometimes it kind of drags along, hence you see those smears. The smears are basically the serum that's kind of dragging along and maybe tumoral material. And this is a very low power view. This is a 2x magnification view. This is the kind of cellular pattern that I see on the slide. So this is what my job as a pathologist begins to try to understand what this lesion is. So obviously on this power you can't tell diddly squat about what these cells look like because you don't see them in large magnification enough. But you know that there is cellular material in there, that this is not just blood, and that there are cells in there. So now, under much higher power, what you can see is that there are cells here which are in particular groups, and now I can begin my job by looking at the relative sizes of nuclei to the cytoplasm and particular sort of layers of organization of these cells, okay? So this already looks like there is a heterogeneity between nuclear sizes, and they tend to be within the same group, which makes me think that this is probably an epithelial malignancy. Now, I ordered cores, we got 2 cores, and now the cores have been processed stained. Now we are in day 2, okay? So FFPE means formalin fixed, paraffin embedded, hematoxyl and eosin. This is day 2. So what do I have on this slide? So let's look at maybe, do I have a pointer? Yes. Excellent. So what you see here on higher power pieces of tissue, and this tissue here, okay, these small blue dots, those are lymphocytes, so this is an inflammation, and then there is this. This layer here is an abnormal epithelium, and what you see here are very large nuclei and very small nuclei next to it. This is carcinoma. Same here. These are extremely pleomorphic cells. The nuclei are not round, they are not reflecting any normal epithelial structure. This is a carcinoma invading into this tissue. So this tissue, actually, do you see these spindly little nuclei? They are much thinner. This is benign, and this material here is new collagen. So this is what's called a desmoplastic reaction, which an invading tumor causes in the surrounding tissue. So right now, I am at non-small cell carcinoma of the lung, okay? And I need to look at more. So this is another core from this patient. So now I'm looking at this, I'm like, here is the invasive carcinoma, okay, these pieces. Here is the dysplasia. Here's a little like a papillary excretion that also is that carcinoma. But now I'm beginning to be concerned because I know from the history that this patient had high-grade dysplasia and might have colon cancer. And now I'm looking at these cells. Look at the red here and at the blue here. This is called palisading. And these cells are polarized towards this end, and they are making their cytoplasm stick out. Same here, right? This is a feature of colon cancer. So now, based on my morphology, based on that whole pattern of recognition of fetal signet ring, mucinous, non-mucinous, now I'm in a box because my differential diagnosis tells me, I cannot really say to Dr. Licht that this is a primary lung cancer. I have to figure this out to make sure that it is, because it could be a metastatic colon cancer based on the morphologic characteristics of this specimen. What do? I do immunohistochemistry. You guys roughly know what this is. I'll spend maybe 2 seconds telling you. All right, so you have this tissue on a glass slide, and then you can apply particular antibody that binds to a specific epitope with that cell. There are some epitopes that are colon specific, some epitopes that are lung specific. One of these is, what a horrible name for students, thyroid transcription factor 1. It's one of the genes that expressed only in the thyroid and in the lung. And the guys who discovered it in the thyroid were first, so now we have TTF1. There are other markers here, such as cytokeratin 7, that's a lower molecular weight cytokeratin, and CDX2, which I don't know what it stands for, I just forgot. But CDX2, thank you. I think it's one of these partition-Hoxing genes, right? I don't know its name. Licht knows. Fantastic. So CDX2 is very specific to mucinous gastric epithelia. Okay? So if it were to be expressed there, and if cytokeratin 20 were to be expressed there, and if TTF1 did not express in the nuclei, and you can see this, decorating nuclei of the cancer, there is no staining in the surrounding stroma or desmoplasia. This is a very specific marker, and every single cancer cell is staining, right? Cytokeratin 7 shows you the infiltration pattern. Cytokeratins are expressed in the cytosol of these cells. They give them structure. So this is like a scaffolding protein. And then by type of different cytokeratin, we have very many, from low molecular weight to high molecular weight. High molecular weight cytokeratin 20 is expressed in colon. Colon cancers tend not to express CK7. Lung cancer, almost 100% of the time, will express CK7. So now, after doing this stain and applying these antibodies, then secondaries, and then using horseradish peroxidase to generate these brown stuff, right? Because the blue stuff is just hematoxylin. The brown stuff is diaminobenzoate, which is basically a chromogen, which, if everything bound correctly and specifically, then you have that horseradish peroxidase, which converts this and precipitates it right on the site of the antibody binding. Hence, you can tell that this is in the nucleus and this is all over the cytoplasm. Okay, so that's the very simple test. That is the mainstay, and this is what we do. So now I am able to say, and this is my diagnosis from which I Adobe smeared out the PHI, so I'm not violating patients' privacy, which are, again, the HIPAA rules. So we have a case number. This is my final report. We have the successioning number, test performed, lung needle biopsy, touch prep, statement of adequacy. It's satisfactory for my evaluation. Diagnostic category is positive for malignancy. And then what is my final diagnosis? Primary lung adenocarcinoma. Okay? So it was making mucinous, it was making glands, that makes it an adenocarcinoma. The stains told me that it's lung primary. I am done. This is the final diagnosis of this lesion. And then this is me, actually. I signed out this case 2 years ago or so. See, so this is how a clinical report looks like for people who haven't seen it. There's eye attending. But this is the problem, see. Because despite me saying that this is primary lung adenocarcinoma, Dr. Lick needs more information to treat the patient, and this is kind of the little core. So even in the realm of medical oncologists, people tend to subspecialize per disease groups, okay? So you have the lung specialist, the breast specialist. Just like in pathology, you have subspecialty training for example, breast pathology. It's much more common at academic medical centers. It also depends on your size because you don't have enough bodies if you have not enough specimens, so there are logistics to it. I am a cytopathologist, so I have to know everything about wherever people can stick needles and core biopsies. But indeed, there are subspecialty sign-outs. For example, I don't touch non-neoplastic kidney. I wouldn't know what to do. Okay? So there are differences in practice patterns, not only between diagnostic pathologists, but certainly between clinicians who are experts at treating a particular spectrum of diseases. And as this gets more complex, the disease spectrum gets narrowed because you need more knowledge per disease unit. Okay? I just wanted to make fun of him, and I'm very thankful to Sheila for allowing me her computer in real time to retype the name of the oncologist in the audience. But anyway, to continue. So then what is that? I took salt, put it on the stage of my microscope on the glass slide, and took a picture. So this gives you a reference point about how tiny lung core biopsies can be and what is really required of that tissue to produce all the spectrum of molecular diagnoses to be sufficient for this assay, that assay, my diagnosis, etc. Okay? So this is just a perspective. I mean, admittedly, these grains are fairly large. I was biased and picked the big ones, but it gives you a size reference. So now, this kind of is a lead-in into a very practical aspect of what I do on site. So see, this is the description below my diagnosis that Dr. Lick never reads because he already has that diagnosis. This is my histologic findings in terms of what I found in a particular subclass of a specimen. So we had touch prep findings, core biopsy findings. There are many other pathology-specific processing steps, and I describe them all because that provides another pathologist or a reviewer the basis for knowing why I said what I said. Okay, so the immunostains are included in here. They were done on core A, not core B, etc., etc. And this is important. See, because this is my triage. So what we do is I know that if I'm going into this with a sort of differential diagnosis of primary lung carcinoma, I know that I'm going to have more specimens to do certain things. And one tiny little core biopsy, smaller than a grain of salt, is not going to be sufficient to do everything. So I will have exhausted jar A by merely doing my immunohistochemistry. That's why I have the jar 2 and 3, because I need to order the necessary molecular tests. And this is a list of common tests in lung diagnostics that are now standard of care. People need to do EGFR sequencing, KRAS sequencing, predominantly to use Tarceva, which is erlotinib, to either treat the patient or don't use it because it's ineffective in the face of KRAS activating mutations. And ALK-ML rearrangements, there's a new drug called Xalkori, that's crizotinib, which was developed for c-Met amplifications, but now is extremely effective in a low percentage cases, about 3% of people who have these rearrangements. So my job doesn't stop. Now day 3 to 7 is I need to do the assays. So what are the considerations? The grind and bind is a term. It's an official NCI term coined by Steve Hewitt. And what that connotes is something very important, because you take this beautiful architecture, you saw the glands crawling through the tissue, you saw the dysplasia, you could tell all these things, and now what you're going to do is you're going to take all this stuff, homogenize it, and extract DNA out of it, thereby losing the distinctions between what DNA is coming from a fibroblast, what DNA is coming from the basal cell surrounding benign lung, benign pneumocyte, and the malignant carcinoma. Okay? So this is extremely important, but then that gets pushed into DNA sequencing for KRAS and EGFR. You can, unlike grind and bind, do in situ analyses which rely on some visual detection of the lesional tissue while this is preserved. So those are techniques of immunohistochemistry. You saw stuff staining here but not there, right? The same can be applied to FISH, which is just fluorescence in situ hybridization, or CISH, which is chromogenic. So fluorescence is based on a fluorescent probe that you need UV light to excite and then get color out of it. It's kind of nice because you do multiple labels in the same cell, and I'll show you why that is important. CISH is just chromogenic. It's cheaper, easier. You don't need fluorescence. It's just much faster to do. Virtually all lung cancer diagnostics are based on IHC, but rearrangements and copy numbers, for example, for HER2 testing, amplification of genes, they are done on FISH platforms. EML ALK rearrangements are done on a FISH. So this is the importance of understanding in detail what our pathology report says, okay, and what it really means. I think that this is too low of a power to tell you exactly what, but you can tell that the first core, okay, our standard care report is 100% tumor. This is primary lung adenocarcinoma. However, it is 80% tumor, 20% fibrosis, and no other contaminants, okay? So fibrosis is not that big of a deal because you maybe have a fibroblast here and there, but mostly you have collagen. The next core has 10% tumor, 10% fibrosis, 80% necrosis. The next one has 60% of benign contaminants. At this point, this becomes important. Where is this signal coming from? And this is very important because I then will, in my molecular pathology lab, have to sequence this stuff and give somebody a result. So Sanger nucleotide sequencing, right, that's old school. This is basically proportional. You now have a spectrum of DNA. Some have mutation, some genes don't have mutation. And what you do is you basically, by these dideoxys, you then resolve by color which has the mutation, which has not. But depends what you put into that reaction, you will see the height of the peak. And that is your only ability to see that mutant. Meaning that if the cancer is about 10% and something else is res, then you don't know. You just have a false negative because you buried that peak and you don't know. So this is why, okay, people developed other assay techniques. Pyrosequencing relies on proportional amplification, but then there is an immobilization and growth of DNA strands based on a very localized beads. And then you have a flash of light to detect whether you flow different nucleotides and either there is light or there is no light, and since you know which nucleotide you're flowing, you can then determine whether or not this was a mutant or a wild type, and that has a lower detection limit. There are other techniques which are selective for detecting mutations, okay? So this is how we approach, and this is what I meant when I said that these endpoint assay technologies which we use in pathology impact how we actually assess tissue and what we do with it. This is important from another standpoint, and let me just tell you before I go to this slide, let me tell you why. Because all these assays are very heavily regulated. You see here terms like PMA filed, QIAGEN as a companion diagnostic, okay? I'll comment on this on my last slide because pre-market approval means that something can be marketed and approved by the FDA for a particular indication. We operate in a CLIA environment. We have to operate in a very regulated way. Some of these assays they take 2.5 years of massive amount of money and work to get to market, and this is what we have to contend with. So we have to be very mindful about how we analyze this tissue and what we put in there. This is just a demonstration of the FISH break-apart probe for ALK-EML. This is an Abbott assay that's a companion diagnostic for crizotinib. And here the issue is if you see red and yellow, that means that the chromosome broke apart and traveled. Okay? So if you see the dots, they are close, then you see the dots spreading apart, that means that rearrangement had occurred. It's a much more sensitive technique to see the spread of the chromosome and look at that rearrangement. So you see a wild-type homozygous nucleus in one end, and then you see this fluorescent probe giving you two different colors, and that's a heterozygous for that mutation. Okay? This is based on knowing where ALK is and knowing where EML is and where the fusion partners happen after the rearrangement. It's a move 2 to 5, chromosome 2 to 5. Okay, this is my last slide, and I want to just give you with the technical limitations or practical limitations of these endpoint assay technologies. So technical limitations, amount and purity. We're getting much better at this because with single strand next generation sequencing, what you can do is you can basically then say, all right, strand by strand, I can analyze the mutants. And if there is a positive signal, unless this is a false signal from something that does not have a driver mutation in it, you have the necessary sensitivity to actually absorb this. Logistics are very important. This is sort of an adult topic for in-house versus sundown. Dr. Lick was talking about it. But here's the situation. Now that we're moving to targeted therapeutics, drugs are being approved with a particular biomarker for their use. You have 3 drugs treating, for example, in melanoma, the same mutation, V600E, and you have 3 different companion diagnostics. Where is the poor pathologist? In order to give that diagnosis to Dr. Lick to treat for a particular drug and then bill Medicare, I have to have 3 different machines and 3 different assay platforms, none of which may actually be scientifically the best for detecting that particular abnormality. So this is where our job in terms of financing and picking these assays as pathologists gets very difficult. The other thing that is already happening is this is a very inefficient use of samples because you balkanize the assay. See the jars? This is our little way to compensate this stuff. But what would be beautiful is an RNA-based assay that can capture essentially the translocations, the copy multiplication, and also point mutations in these genes, along with methylation of epigenomics on one platform in one sample. And people are developing assays that way. People are developing technologies to capture this. The other thing is financial. This is entirely an adult topic, but then again, I showed you guys the H&E, right? And how I could make an adenocarcinoma, primary lung adenocarcinoma diagnosis with a few H&Es. That's maybe $350 in terms of cost. If you start adding molecular technologies, that grows up to about $3,500. So then my hospital administrator comes to me and say, Peter, we have diagnostic reimbursement groups. Lung cancer treatment was say $4,000, still is $4,000. And 3 years ago, you could make this diagnosis for $400. Now you're asking for $3,500. So there is a profound impact of these molecular technologies and how pathology is embedded in the context of treatment of patients. Also for financing of the endpoint assays and end results, which is hopefully getting resolved now because the complexities obviously grow. And it's not like we're going to stop using these technologies. They are the underpinning of the next generation of clinical trials. And they are everything as far as personalized therapeutics and appropriate matching of particular molecular abnormalities in cancer to the particular therapeutic agents that we're going to use to treat them with. So with that, I think I'll stop. Am I on time?